Hello everybody and welcome back. This will be the final PowerPoint for EKGs. We're going to discuss several things. Should be a fairly short review. A lot of this stuff we've really already discussed before. Really probably just kind of give a brief overview. We'll talk a little more about the treatment for some of the arrhythmias that we've talked about, our ACLS guidelines, and what the recommendations are for treatments. We'll do a brief talk on defibrillation and cardioversion because I don't believe I've covered it to this point. Then we're going to talk about some of the cardiac meds that AEMTs are going to be allowed to administer. Then we're going to go over a few common cardiac meds, and then that's really about it. So, ACLS, Advanced Cardiac Life Support, is a class sponsored by the American Heart Association. Every 4 years, the American Heart Association gets together. They work on it for, around the year between guidelines that are published. I mean, they're working on it continuously. They look for up-to-date research. Perform research. They take all the information that's available, and then they establish guidelines for the treatment of cardiac problems. They have a wide range of information that they publish. We're not going to get into all of the different guidelines that the AHA has because they fill journals. The AHA has their own entire journal just filled with guidelines of stuff that they have, come up with over the years and stuff. So, not really practical to go over that, but there is a lot of information out there. Advanced Cardiac Life Support is not really what it used to be. Whenever you took the class back whenever I first started in this line of work, it took about a week to do. The book was about as thick as a 3-ring binder. It was a good sized book, and it was pretty difficult. People often failed ACLS. Well, the AHA has had a big push to get as many people ACLS certified as they could. So they really have kind of dumbed it down to where you can do it in a day. The book is about it's about 30 pages, and it's just not nearly as in depth as it used to be. They've pretty much canned everything down to some checklists and check sheets and flow charts. So we are going to go over some of those. Although they have been dumbed down, they are still pretty useful. It just kind of gives us, keeps in mind what we need to be considering whenever we're treating specific patients. ACLS is not an inclusive set of guidelines. They are guidelines, they're not rules. Depending on where you work, they may have deviation from ACLS. Because for whatever reason. So if your medical director or wherever doesn't agree with ACLS, he has the right to he has the right to veer from what ACLS recommends. And it's not that uncommon. There's a lot of people that or a lot of places, services that don't necessarily follow completely down ACLS's guidelines because they're not always on the very forefront. Sometimes research comes out before the next ACLS guidelines are published, and people want to jump on board and start following with the most up-to-date research. So they may not be in line with ACLS at all times. It's okay. This over. Okay, so our first algorithm that we're going to look at is the cardiac arrest flow chart. If you guys have worked anywhere in an EMS service, and you're probably fairly familiar with the flow of a cardiac arrest call, how those should pretty much go. If not, this is just kind of a rundown of the way that traditionally a cardiac arrest is going to be run. And just remember that in a lot of EMS systems, they are kind of going away from this particular model to one that's similar that we will talk about on the next slide. It just depends on where you work right now. So in our cardiac arrest, obviously we need to start CPR with high quality, good quality CPR. as we've already discussed, CPR quality, good quality CPR is going to be a very good link in the chain to survival. So you guys should all be familiar with the proper procedures for performing CPR. So we need to apply our cardiac monitor. We're going to check for a rhythm. If we do have a shockable rhythm, we're going to administer defibrillation. Our shockable rhythms are VFib and VTAC. If we don't, or we have asystole or PEA, we're going to continue CPR. We're then going to obtain vascular access and administer epinephrine. We'll get into the details of epinephrine on the next on our next segment here. That's basically what we're going to do. We're going to, every 2 minutes, we'll stop and check our rhythm. If we have a shockable rhythm, we'll shock it. If not, we'll continue CPR. After we shock, we always continue CPR. If we do have a shockable rhythm, VFib or VTAC, we can administer amiodarone, which is antidysrhythmic, which we'll talk about in more detail here in a little while as well. So that's basically about it. Our biggest thing here is minimizing interruptions in CPR. We're going to consider our reversible causes. Our H's and T's are listed down at the bottom here. A lot of these can be reversed by us. We do have the mechanisms for treating these causes of cardiac arrest. So hypovolemia, obviously we're going to be able to address that by providing fluid. Hypoxia, we're going to be able to address by providing oxygen. Any type of acidosis, hydrogen ion is talking about acidosis. We'll be able to, if we have the standing orders for that, we can administer sodium bicarb to assist in the reduction of that acidosis. Hyper and hypokalemia. We can't really do anything about hypokalemia. There are, like we discussed in the previous lecture, we can treat hyperkalemia with our calcium chloride and our sodium bicarb. That's not specifically something that AEMTs are going to be able to do, but if you're working on a paramedic you will, be familiar with that. The next one is going to be hypoglycemia, which can be reversed with dextrose, and hypothermia, which we're going to fix by warming the patient. Toxins, there's not generally very much we're going to be able to do about that. Tamponade is the same way. We're not really going to be able to fix that. We can fix tension pneumos by doing chest decompressions. Don't believe that A's are allowed to perform chest decompressions, but you'd have to ask somebody about that. Thrombosis, again, not really a whole lot we're going to be able to do to treat any thrombosis in the pre-hospital setting. And then trauma, obviously our main treatment for trauma is to transport to a trauma facility. Okay, so the difference here, we're going to talk about the next flow chart here is continuous compression resuscitation. Basically, this is just kind of a new take on treating adult cardiac arrest. So basically, we kind of start the same. We're going to start our CPR. We're going to, instead of using a bag valve mask for ventilation, we're going to provide oxygen via non-rebreather. We'll apply our cardiac monitor, check our rhythm. If we do have a shockable rhythm, we're going to shock it, and then we're going to continue CPR. So basically the big thing here is that we are going to have much more focus on minimizing our CPR interruptions. We do basically whenever we're doing this particular form of CPR, we're going to try and get 220 compressions per minute, which is 220 compressions over 2 minutes, which is going to be 110 a minute. Generally, with CCR resuscitations, there will be a metronome present to assist the providers in maintaining the appropriate rate on CPR. Our drug therapy is still going to be the same. Advanced airways are generally considered later on. We're just going to leave that non-rebreather on. They've found that non-rebreather with the negative pressure in the thoracic cavity with chest compressions will actually draw oxygen and draw oxygen in just about as good as we can provide our bag valve mask ventilation. So really that's the biggest difference, is that we're not going to have our pauses in there to administer our breaths. It's just continuous compressions until our rhythm checks. There's a big emphasis on rotating compressors to make sure that we don't have tired people, to make sure we're getting good quality CPR all the way through. And then if we do have a return of spontaneous circulation, we are going to obviously monitor our pulse and blood pressure, and then usually evidence of return spontaneous circulation is going to be abrupt increase in end-tidal CO2, which is something that you guys probably haven't discussed at this point, but you will. Biphasic defibrillation is going to be our key here. Not really very much monophasic defibrillation being used anymore. And then again, treating our reversible causes and providing an advanced airway. And we'll talk a little more about defibrillation later on. Okay, so our next algorithm we're going to talk about is our adult tachycardia algorithm with a pulse. Basically, the big thing here, we're not talking about sinus tachycardias, we're talking about tachyarrhythmias, SVTs, and VTAC. Our biggest thing, we're going to start by assessing our clinical condition, determining if our patient is stable or unstable. We need to maintain our patent airway, provide oxygen as needed. Obviously, we're going to put our cardiac monitor on. So if we have an unstable patient, evidenced by shock symptoms, hypotension, altered mental status, ischemic chest discomfort, or acute heart failure, we're going to immediately move to synchronized cardioversion. We'll discuss that later on. We will go ahead and cover our doses here. Pretty simple on the doses. Just kind of look at these over here on the right hand side. You'll notice that our synchronized cardioversion doses, if we have a regular rhythm with a narrow QRS complex, we're going to start at 50 joules of cardioversion. If it's irregular, our narrow complex irregulars are going to begin at 120 joules. If it's wide and regular, we'll begin at 100 joules of energy. And if it's wide and irregular, this is not going to be cardioverted. It's going to be defibrillated at 200 joules. So if we do have a stable patient, which generally our SVT patients and stuff like that are generally fairly stable, we are going to move down to the next box, number 5, which asks us if the QRS is wide. If the QRS is wider than 0.12 seconds, we are going to consider an antiarrhythmic such as amiodarone. We'll discuss that here later on. Procainamide, not really carried by services around here. So for stable, wide complex tachycardias as AEMTs, there's not really a whole lot that you're going to be able to do. If we have a narrow complex tachycardia and they are stable, then we're going to consider our adenosine and vagal maneuvers. I don't think that we've talked about vagal maneuvers. Something that you guys should be familiar with. They're not really that are going to be done by AEMTs, but basically a vagal maneuver is something that's going to stimulate the vagus nerve. That can be very useful in helping terminate supraventricular tachycardias. The most common vagal maneuver is going to be a carotid artery massage. The general rule of thumb on vagal maneuvers is not to perform them on patients that are over 40 years of age due to the risk factors that can be involved. So with carotid massage, it's exactly how it sounds. You just massage the carotid artery. And this stimulates the vagus nerve and causes a parasympathetic release that can slow the heart rate down and knock out that SVT. Valsalva's maneuver. There's a ton of different vagal maneuvers, having the patient bear down like they're trying to have a bowel movement. If you remember, that vagal nerve actually comes down from the brain and goes down all the way down to the lower intestine, and then wraps around the lower intestines and comes back up to the brain. So there's pretty much multiple different ways that it can be stimulated due to the large size of it. So other than that, basically that's going to be about it on our tachyarrhythmias for you guys. Now move on to our bradycardic rhythms now. Okay, so for our bradycardias, again, we're going to start by assessing our patient, determining if they're stable or unstable. Bradycardia is, typically under 60 beats a minute. They can be symptomatic usually when they get below 50 beats a minute. So on all our patients, but with these specifically, we're going to maintain a patent airway, provide oxygen, cardiac monitor, IV access, and 12-lead. Determining if the patient is stable or unstable. If the patient is stable, we have to, we're not really going to do a whole lot to treat this. If they aren't stable, we can consider atropine usage or transcutaneous pacing, dopamine, or epinephrine. Our dose for atropine is going to be 0.5 milligrams up to 3 milligrams in total. That is for paramedics. AEMTs are not going to be allowed to administer atropine. Basically, for you guys, the biggest thing here is going to be to monitor your patients. If they do require some sort of intervention, it's going to be a paramedic that administers it. Okay, so the next one we're going to talk about here is our acute coronary syndrome. These are our chest pain patients. Really just kind of focus on our first big box here, and then talk about our treatments down below. So our EMS assessment is we're going to be monitoring, supporting ABCs. We're going to obtain our 12-lead ECG. If we do have ST elevation, we're going to notify the receiving hospital. We're going to note the time of onset of pain and first medical contact. And then the hospital is going to activate their resources to respond to the STEMI. And then not really anywhere around here is doing pre-hospital fibrinolysis, so not really something that needs to be considered. Basically, our big indicator here, if you look down at the bottom at our reperfusion goals, the therapy here is, if you see the door to balloon inflation time of 90 minutes, and then the door to needle time of fibrinolysis goal of 30 minutes. Our biggest thing here is time. We do have our treatments that we're going to give en route and when we're with our patient, but the definitive treatment for these patients is in the hospital. So that's really where we need to focus on getting them, not diddle daddling around on scene and doing more stuff than is necessary. So if you guys want to go over this stuff and what the hospital is doing for these patients, it's pretty good information to know, but it's not something we're going to cover right now. Next algorithm that we'll look at is the stroke algorithm from the AHA. You guys will talk about strokes and stroke screens in a different section, but we'll talk about them here. Um, uh, Basically, whenever we do have a stroke alert, we are going to rapidly transport our patient to the hospital. There generally most systems have a alert in place where you are going to call and advise them of a possible stroke. Our biggest indicator here is that if they do have an occlusive stroke, then they can be possibly candidates for fibrinolysis or clot busting drugs. There is a lot of prerequisites that have to be met for fibrinolysis. Usually, 3 hours is about the 3 hours from onset of symptoms is the maximum time after onset that they're going to be able to be a candidate for fibrinolytics. So, it is important for these patients to be rapidly transported as well. So this particular algorithm is much more hospital oriented and doesn't have a lot of pre-hospital play. This is the checklist for fibrinolysis here. If you want to look through that, just to kind of have an idea of what criteria the patient has to meet to be a candidate for fibrinolysis. It's some pretty good information, but we're not going to cover it in detail right now. So moving on, you guys have should be familiar with the terms defibrillation and cardioversion. We have not yet discussed these in depth. We are going to go ahead and talk about those for a few minutes. We'll talk about cardioversion first and talk about what the differences are between defibrillation and cardioversion. Cardioversion is a synchronous delivery of electricity. It's usually not usually. It is designed to be a measured electrical stimulus that's provided on the upstroke of an R wave. Generally beginning with a lower energy setting than defibrillation. Cardioversion is used in pulsatile rhythms. Note here it says that you need to hold the button. So and you guys will go over this during labs when we're looking at our cardiac monitors and stuff. But just be aware that whenever you on any cardiac monitor that can provide defibrillation, they're generally set up to provide both defibrillation and cardioversion. Whenever we're cardioverting somebody, you'll find a button on the cardiac monitor that says sync, and we'll talk about that in class. We'll look at it. Whenever we're using this synchronized cardioversion setting, we'll push that button, and then the machine will start tracking the QRS complexes, and specifically the R waves. Whenever it has a track of the R waves, it'll tell you. We'll start seeing arrows over each R wave that occurs. Whenever you go to administer the electricity, you have to hold the button down because the machine waits until it knows where an R wave is going to occur and then provides the electrical stimulus on the downstroke of the R wave. This is to prevent electricity, and like we said, it is provided for pulsatile rhythms, and the reason that it is provided, the stimulus is provided on the R wave, is to prevent an R on T phenomenon from occurring. So basically what we don't want to happen is to provide that electrical stimulus and the shock happens on a T wave, and we have basically a giant PVC that is being forced onto the preceding T wave. This can incite lethal arrhythmias such as asystole and VTAC and VFib, which we do not want to do. So that's really the big difference between cardioversion and defibrillation. It is a synchronized electricity stimulus, and it is used in pulsatile rhythms. Defibrillation. There's two types of defibrillation. Most commonly used now is biphasic. Monophasic, the energy travels in one direction. Biphasic, the energy travels back and forth between the two fast patches or pads that are placed on the patient. Defibrillation is used in non-pulsatile rhythms, and it always moves from the negative electrode to the positive. Most current cardiac monitors use biphasic defibrillation. The dose is 120 joules to 200 joules. It depends on the manufacturer recommendations as to what energy setting you should start at, as well as local protocols and local jurisdiction. Biphasic defibrillation does prevent myocardial damage. You don't see surface burns like you used to see with monophasic defibrillation, and there's greater incidence of survival to discharge. You do have some of our AEDs. You do have automated versus semi-automated. Not really. Depending on where you work, if you have a cardiac monitor, then that's not really something that you're going to have to deal with because you do have control of the monitor and when it's going to provide stimulus. But if you are working in a first response agency that only has AEDs available, you do have automated AEDs and semi-automated AEDs. Fully automated, they basically go through and do everything for you. They analyze the rhythm. They tell you to shock, and some of the older ones would even provide the shock without you telling it to. Semi-automated is kind of the newer trend. It still voice prompts you to do these things, but you have to push the button for it to analyze. You have to push the button for it to shock. So that's the big difference between fully automated and automated. All right, so we're going to talk about our cardiac meds that you guys are going to be giving for acute coronary syndromes. There's generally 4 cardiac meds that are administered in the pre-hospital setting. Those are morphine, oxygen, nitro, and aspirin. You guys really only need to be familiar with 3 of those because you're not authorized to administer morphine for cardiac-related chest pain. So we're going to talk about some nitro, aspirin, and oxygen. So you guys should be familiar with most of these because you've been through an EMT basic course, and these are all medications that can be administered by EMTs. So the biggest difference is that you're not assisting the patient with it. You can provide it without. You can do it by standing orders using the medications that you have in the ambulance or on scene with you or whatever. So as you guys know, just brief talk this over. The dose for nitroglycerin is 0.4 milligrams sublingual. It dissolves under the tongue. It is contraindicated in patients that have recent use of erectile dysfunction. The only thing to remember really is that we need to be cognizant of patients with possible right ventricular wall MIs and be very cautious with our nitro administration in them. And like we said, it is sublingual in nature. Depending on where you work, you'll see different variations of how much nitro you can give. Generally, the most common one that I've seen today is that you can give as much nitro as long as you maintain hemodynamic stability or a systolic blood pressure of 100 or greater. Nitro, as you guys are aware, is a vasodilator that is given to reduce preload, reduce the workload of the heart, and cause dilation of the coronary arteries to permit oxygenated blood to bypass a clot when it is present and reduce myocardial damage. Aspirin is an antiplatelet or a platelet inhibitor that is given to acute coronary syndrome patients to prevent further deterioration down the clotting cascade. It is given prophylactically to most chest pain patients. The dose is 324 milligrams PO. Very few contraindications unless a patient's cardiologist has told them to not take aspirin or their primary care physician because they have a stomach ulcer or some type of bleeding disorder. Generally, there's a few contraindications to aspirin. Pretty much any acute coronary syndrome candidate can get these, and as we said, the route is PO. Oxygen, the dose is generally anywhere from 2 to 15 liters per minute, from nasal cannula to non-rebreather. Not really any contraindications to oxygen therapy in the pre-hospital setting. The who gets these is kind of an interesting question here. In recent years, up until recent years, prophylactic oxygen administration has been very common, and the fact of the matter is that we're starting to realize that oxygen is not without its catch-22. Long-term oxygen administration can actually cause tissue necrosis. It increases free radical um, increases free radical release into the bloodstream and cause increased myocardial damage in patients that are ischemic. So the days of providing oxygen to everybody, no matter what, are kind of going by the wayside. Generally, the AHA right now recommends that prophylactic oxygen administration should not be given unless patients have a O2 saturation beneath 94% or they have a complaint of dyspnea or shortness of breath. So we're going to talk about some of the other first line cardiac meds that can be utilized by AEMTs. Pretty much all of our first line cardiac meds in cardiac arrest can be administered by you guys. So we'll go ahead and talk about those now. There's really three meds that we're going to focus on right now. That's going to be epinephrine, amiodarone, lidocaine, and then real briefly, I'll talk about atropine and dopamine. Atropine can be administered by AMTs in the setting of organophosphate poisoning. It is considered to be a cardiac medication because of its anticholinergic effects, but for cardiac problems, it is not to be administered by advanced EMTs. Dopamine is another cardiac medication that is commonly used to treat shock patients. Generally, good for cardiogenic shock, but the most, pretty much any type of shock can be treated with dopamine. But this is something that is a first line medication that's administered by EMT or AEMTs, but it can be monitored during transports, during transfers from facility to facility. AEMTs can monitor the administration of dopamine. Okay, so first we're going to start talking about epinephrine. Epinephrine is let's just go to the next slide here since I don't have you guys in person to tell me the answers to these questions. Epinephrine is a sympathomimetic, meaning that it's going to increase the adrenergic receptors throughout the body and increase the sympathetic nervous system pretty much all throughout. It does have more alpha properties than beta, so it is going to cause more vasoconstriction than it is going to cause anything to happen in the in the lungs. The dose for epinephrine is 1 milligram every 5 minutes. It's 1 to 10,000, meaning there's 0.1 milligrams in 1 milliliter. So a 10 milliliters pre-filled syringe is going to equal our dose of 1 milligram. It can be given IV, IO, or down the ET tube. It's given to any adult in cardiac arrest, and there's no contraindications for epinephrine in cardiac arrest. And like we already discussed, it comes in a 1 milligram, 10 milliliter concentration for cardiac arrest. Epinephrine does have multiple different uses for anaphylaxis, for bradycardia and pediatrics, especially, and for asthma in very severe cases. But for these purposes, AMTs are only going to be administering epinephrine for cardiac arrest, and then I believe you can assist with, or you can administer it for anaphylaxis as well. But that's a different dose that you guys will discuss at a different time. All right, amiodarone is another medication that you guys will be able to administer. It is a class 3 potassium blocking antiarrhythmic. I haven't really discussed the classes of antiarrhythmics since there's only a couple of them that you guys are going to be able to administer. If you guys remember, go way back to one of the very first lectures when we were talking about our cardiac action potential, when we have our sodium influx and potassium efflux. Basically, this is where our antiarrhythmics are working. They're working on those action potentials to slow conduction. They decrease the ventricular fibrillation threshold, and they can convert rhythms from generally what we're expecting to do. We're going to be giving our amiodarone for VFib, VTAC cardiac arrest to hopefully convert them out of that into pretty much anything else. We'll take it. The dose for amiodarone is 300 milligrams IV bolus, and then 150 milligrams after 5 minutes. The maintenance dose, which I'm not real clear on whether that can be set up by you guys or not, but the maintenance dose is 1 milligram per minute. It's actually 360 milligrams over the next 6 hours, but 1 milligram a minute is good enough for us because we generally don't have these patients for 6 hours. It can be given IV or IO. Like we said, it's given for VFib and VTAC cardiac arrest. There's very few contraindications to worry about in cardiac arrest. The concentrations are various depending on where you're working at, but 50 milligrams per ml seems to be a pretty common one that's being used. Lidocaine is another antiarrhythmic that is allowed to be administered by you guys. It's a class 1 sodium channel blocker. It is not really commonly carried. It's really fallen out of favor due to amiodarone. Amiodarone is a much more common antiarrhythmic used. You don't really see lidocaine as a first-line antiarrhythmic really anywhere that I know of right now. The dose for lidocaine, though, is 1 to 1.15 milligrams per kilogram IV push, and then it's repeated at half that in 5 minutes. It can be given IV or IO. There's no contraindications in cardiac arrest, and there's multiple concentrations seen. Post cardiac arrest, the maintenance dose for lidocaine is 1 to 4 milligrams per minute. Okay, now that we've talked about the first line cardiac medications that you guys are allowed to give, we're just going to real quickly go over some of the medications that you'll see patients have prescriptions for. Noting the prescriptions that somebody is taking is a really good way to learn a lot about your patient and their history. So it's not really something you need to memorize. You'll get to know them as you work somewhere and you see these medication lists that people are taking, and you'll become familiar with them the more you run into them and realize what they're being given for. The first ones we're going to look at is our anticoagulants. Here's a big list of them here. The most common one I would say is going to be warfarin or Coumadin. Heparin's fairly common as well, and Lovenox is a pretty common one too. You'll see these given to patients with generally with AFib or other clotting disorders. Biggest problems that you'll run into with these is that they haven't been, or they've had dosage adjusted, and they're either their blood's clotting too much or it's not clotting at all, and you can run into some problems from that. Just take note of the names here. Not really biggest thing here. Anything that ends with ARIN is generally going to be an anticoagulant. Likewise, our antiplatelets here, aspirin, clopidogrel are very common. Clopidogrel is just the trade name for Plavix. Pretty common ones to see. Patients that have coronary artery disease are going to usually be taking one of these. Patients that have a history of MI, clopidogrel is a pretty common one that they'll be taking for the rest of their lives. All right, here's a big list of ACE inhibitors. ACE inhibitors stands for angiotensin converting enzyme. These are blood pressure medications generally. Anything that ends with pril is generally going to be an ACE inhibitor. So, pretty common are going to be Vasotec, the enalapril, and lisinopril as well, are probably the most common ones that I run into. Low tensin is pretty common too. Just blood pressure medications. Okay, these are ARBs. Those are a newer class of medication. They stand for angiotensin receptor blockers. They're also blood pressure medications. Losartan is extremely common, taken a lot of. It's given very commonly these days, and Diovan or valsartan is pretty common as well. Real quick, in case you guys are curious what they're talking about, and with the angiotensin, this is a just real quick graphic of the angiotensin, the renin-angiotensin aldosterone system. This is basically a brief graphic that explains how your blood pressure is regulated in the body. So I'm not going to go over it. It is pretty interesting though. And if you go to paramedic school, just know that you will have to memorize this verbatim and probably draw this picture and label it and know it backwards and forwards. So be prepared for that if you have any plans of going to paramedic school anytime. Okay. Here's a list of beta blockers. Just be aware there's a kind of wide range. Beta blockers are extremely common. There's multiple generations of beta blockers. You have first, second, and third generation ones. Beta blockers act on the beta cells of the sympathetic nervous system. They're beta antagonists, so they're generally going to work. Basically, the thing to remember about the generations that first generation beta blockers are non-selective. So our beta receptors are mostly located in our lungs and our heart. So a non-selective beta blocker is going to act on both of those. So if you guys think what your albuterol is, it's a beta agonist. So a first generation beta blocker is going to be a beta antagonist. So it basically is the opposite of an albuterol. It's going to slow down the dromotrope, slow chronotrope. It's going to decrease our heart rate, and that's the idea. It's given for blood pressure. It decreases heart rate, decreases speed of conduction, decreases cardiac output. The unintended consequence of that is that our non-selective beta blockers are also going to can cause bronchoconstriction, relative bronchoconstriction in the lungs as well. That's why there's usually an asthma warning associated with most beta blockers, that they need to be cautiously administered in patients that have asthma. These are all fairly common. Atenolol is up there. The bisoprolol, hydrochlorothiazide is very common. Metoprolol, propanolol, and sotalol are all very common ones. All right, these are calcium channel blockers. They're given for the same thing, for high blood pressure. The biggest thing to remember here, anything that ends with a "ene" is generally going to be a calcium channel blocker. I don't think I mentioned it, but on the last one, anything you probably noticed, anything that ends with all, the sotalol and labetalol, etc., those are all beta blockers, and the enes are all going to be calcium channel blockers. The Norvasc is pretty common. Cardizem, diltiazem are pretty common. Nifedipine as well, and verapamil are all very commonly administered. Calcium channel blockers can also be given as antidysrhythmics as well, but in the prescription chronic usage phase, that's not really what they're given for. They're generally for high blood pressure. Okay, these are all cholesterol lowering drugs. The big ones these days, I'm sure you guys have all heard of them, are statin drugs. Simvastatin, pravastatin are very common. They're just the ones given for high cholesterol. So you'll see these in a lot of patients that have a history of coronary artery disease. All right, these are a list of our diuretics that you'll commonly see. Given for generally given for patients with congestive heart failure, renal failure, patients with, and they can be given in combinations with other medications for high blood pressure as well. Probably the most common ones here are going to be your bumetanide or Bumex, and then furosemide is extremely common, and hydrochlorothiazide is a pretty common one as well. These are our vasodilators, just different brand names. They're all kind of have the same mechanism. Our nitro is going to be our most common vasodilator that you see in the pre-hospital setting, or whenever you're running into patients. This is generally what they're going to have for a vasodilator if they have been prescribed one. And you guys have heard me mention this drug a number of times, digoxin and lanoxin. These are our common drugs that are administered for atrial fibrillation, for long-term usage to slow down the atrial rate and strengthen the myocardial contraction. Okay, guys, this is the conclusion of our PowerPoints on EKGs and cardiac emergencies. If anybody has any questions, feel free to contact me by email, or generally my phone number is on here. Text message is the best way to get a hold of me. If you're having any struggling with any concepts, or we will see each other in class, and so we can discuss any of your. Go ahead and proceed to the quiz on our little summary here, including our cardiac drugs. And hope everybody has enjoyed this lecture, and I look forward to seeing you soon in class.